One of the first things that tends to be brought up in this topic is, well, I have experience with onasemnogene apoparvovec, therefore, I'm ready to do this next thing. And I think most of us that are specialized in this area are concerned with that approach because there's so many things that are different about a Duchenne muscular dystrophy gene therapy experience than what we know from dosing people with SMA. Some of the major ones to consider are that we were dosing quite young individuals with gene therapy, and so the total amount for weight was quite small, given that the maximum was 2 years of age once this came into the clinic in this country. They also, with SMA, knew survival motor neuron protein or SMN protein. They made it with their SMN2 gene. And these people with dystrophinopathy often can't make any form of dystrophin that's recognizable with their own body. And so when we're infusing these microdystrophin transgenes, they're seeing something that is foreign to them. And that makes that much more likely to have a risk of adverse event than what we were seeing in the SMA experience. And then the last thing to be very aware of as a broad concept is that the people with Duchenne muscular dystrophy have a higher burden of multisystemic disease based on their natural history than the people we were dosing with SMA. Some of the very severe SMA patients had multisystemic involvement, respiratory failure, maybe even heart disease, but most were quite healthy other than their motor neurons. And the DMD patients are not like that. They have cardiomyopathy, they have early respiratory involvement, they have mild liver inflammation or sometimes fatty liver changes. They have endocrine vulnerabilities from hypercholesterolemia and other issues that we know about based on natural history, but also makes them more vulnerable when they're put through the stress of a gene therapy dose. And we need to be so conscious of this as a community to both be very stringent about our inclusion criteria for who we might dose. Do we have to consider genotypes? Do we have to consider the immune phenotype of whether somebody might be more prone to reacting based on their HLA type or some other things that we can measure in terms of immune function? And then also, how are their various systems in terms of their reserve? Are we worried that they might not have much cardiovascular reserve? Are we worried that they might have too much underlying liver disease at baseline to tolerate the stress of this therapy? And this is something that we have to learn a lot more about as a community, but much of it will be learned in the real world experience with actual patients.